Hi everyone, this is Dr. M.N. Bhat, consultant cardiologist, KMC Hospital, Mangalore. Today I'll discuss about the latest update in hypertension. As per WHO, nearly 63% of the total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular disease. This cardiovascular disease affects 45% people in the age group of 40 to 69 aged. Raised blood pressure is among the most important risk factors for cardiac diseases. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through the primary care, and poor follow-up. In India, the prevalence has gone up over the period of last 30 years to the tune of about 38% in males and 32% in women. Earlier, it was 29% and 28% respectively, that is about 30 years back. So, over a period of 30 years, there has been a significant increase in the prevalence of high blood pressure, both in males and females. Despite this, nearly half of the people of males and 40% of ladies with hypertension, they are unaware of the condition or they are not taking medicines. Another 62% of males and 53% of females are living with hypertension and they have not got any treatment. Medication was used to control blood pressure in less than 1 in 5 males and 1 in 5 women with hypertension worldwide. The International Society of Hypertension has released the latest ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms attempt to address the issue that in resource poor settings. Optimal care refers to evidence-based standard of care, whereas essential standard refers to minimal standard of care to allow specific of essential standards of care for low resource settings. The AHA-ACC has also released a scientific statement in 2021. It is offering new guidance for management of stage 1 hypertension among the patients who are at a low risk of atherosclerotic cardiac or vascular disease. Among the low risk adults who are not having atherosclerotic disease or whose 10 years cardiac risk is less than 10% and who are having stage 1 of hypertension of BP of 130 to 139 systolic and 80 to 89 diastolic, the management will start with non-pharmacological therapy, that is no drugs initially. So if the blood pressure, that is in the form of diet or exercise, if blood pressure remains not controlled over the next 3 to 6 months by diet and exercise, then you should consider starting medicines. Acute respiratory distress syndrome or ARDS is one of the potentially fatal conditions involving the lung damage, and experts have attributed it to severe COVID pneumonia in the recent times. A recent study which appears in the Journal of American College of Cardiology reports that the metoprolol can reduce this kind of lung inflammation and improves the respiratory function in people who are having COVID with ARDS. Lowering the systolic blood pressure targets down to 110 or less than 130 range substantially reduces the cardiovascular adverse events in the STEP trial, affirming the SPRINT trial findings for the older Chinese population. Among the 8,500 patients of 60 to 80 years in China, the intensive treatment targeted the trimming 26% of this resulted in trimming the cardiovascular risk by 26%. This finding from now a second major trial supporting the lower target could unite the guidelines, which even among the US professional societies range from threshold of 130 to 150. With regard to the prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European Guidelines on the Management of Arterial Hypertension recommends that the diagnosis of high blood pressure should not only depend upon the office blood pressure, but it should also depend upon the out-of-office measurements, such as the ambulatory blood pressure measurements or home blood pressure monitoring. 24 hours monitoring and nighttime BP measurements, they were associated with greater risk of mortality and more chances of composite cardiovascular outcome. Thus, they may be considered as the most relevant measurements for the estimated cardiovascular risk. For every 20 millimeter systolic and 10 millimeter diastolic increment of blood pressure measurement at night, the risk of mortality increases by 23% and risk of cardiovascular events such as the myocardial infarction increases by 36%. Most of the patients with high blood pressure require lifelong medical therapy to achieve the optimum blood pressure control. 2018 European guidelines equally recommends 5 classes of antihypertensive treatment. Considering high non-adherence to these treatments, the importance of combination therapy is particularly highlighted to improve the adherence to therapy and improve the blood pressure control. Therefore, the 2018 European guidelines recommend, especially in the context of lower targets in blood pressure, to start antihypertensive therapy with initially 2 drugs in a single pill combination. Either AC inhibitors or ARB is one of the medicines. The second medicine will be calcium channel blockers or diuretics. One of these 2 medicines are combined together into a single pill and given to the patient. This will result in better adherence and better BP control for the patient, and also it will be cost saving to the patient. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is that detection of a carcinogen, namely NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO International Agency to be carcinogenic. If 1 lakh patients would have received NDMA contaminated valsartan every day for 6 years in high dose, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer patients in 1 lakh patients population if they have taken the high dose over 4 years. So, valsartan recall accompanied by a significant increase in the rate of emergency department visit of plus 6%. The HYGEA study, which is a recent study, represents the largest study that tested nighttime antihypertensive therapy. In this trial, chronotherapy was associated with significant reduction in the endpoints, including death. The HYGEA chronotherapy trial tested whether the nighttime therapy in comparison to the usual blood pressure therapy in the early morning, whether the night therapy will have a better favorable outcome. The largest study, that is the HYGEA study, included 19,000 odd patients with hypertension. During the average follow-up of about 6.3 years, 1,752 participants experienced a primary outcome, and an ambulatory blood pressure was performed for 48 hours to collect data on how BP differed during sleep. The relative reduction for cardiovascular death was significantly improved by giving the BP medicines at night time as compared to the early morning therapy. Thank you for your patient listening.